Good afternoon and welcome to Houston Methodist's Town Hall Series. Today, it's great to see everybody this afternoon. I want to thank the Society for Leading Medicine again for chairing this and hosting this. I'd like to thank Jeremy and Caroline Finkelstein and George and Catherine Masterson for chairing the Society for us this year. If you'd like more information about the Society, we'll have that, including an email address, at the end of today's event. It'll be emailed out to you as well with the slides when we send those out. Today we're going to try to go pretty quickly through our formal presentations and then quickly get to your questions. We received over 100 questions this week, which is a great response because there's so many questions about vaccines and vaccine rollouts. So we want to get to those as best as we possibly can. Many of the answers and the questions and their answers will be embedded in each of our presentations as well. I'm joined again today by Dr. Dirk Sostman, our Chief Academic Officer, who's going to talk to us in detail about some of the clinical and scientific evidence behind the vaccines. We'll also be joined a little later by Roberta Schwartz. Many of you hopefully saw Dr. Schwartz on the front page of Texas Inc. in the Houston Chronicle on Monday. It was a great review of her activities as our incident commander this year, and she's been heading up our vaccination efforts. So we will enjoy having both of them with us. And then finally, I want to remind you again, we have Dr. Ashley Drews on the webinar right now, so she is there to answer any of your questions in the chat box that you would like answered. So encourage you to ask those, and she will get you answers as quickly as possible. So let me just review for you the situation here in Houston right now in terms of coronavirus. We're definitely in a better place than we were the last time that we talked. But what you're going to see is sort of parallel data on each of these slides to suggest that getting the number of infections down and the people in the hospitals down is probably going to be a slower, more drawn out process than it has been in the past. So this is the number of people each week on average that are diagnosed positive with COVID in the greater Houston area. Of course, throughout this pandemic, we've had increasing access to testing. So you have to take the raw numbers with a grain of salt. But directionally, what we see now with relatively real-time numbers is things peaked, they came down, but have not completely come down, obviously, and even bumping up from week to week. We do see lower numbers this week, so I'm hoping our average this week so far, or once it's out, will be lower as well. At Houston Methodist, what you can see here is the number of tests in the blue, but what you see in the orange is the percent positivity rate. And so whereas we went far higher in terms of the positivity rate, the number of tests that were positive, or the percentage of tests that were positive, that number has come down pretty significantly. And now, even though it was well above the July peak, it is now well below the July peak and has come down a good bit. However, still a long way to go and well over 20%, which is a very significant positivity rate still in our community. And you see the slope of that really is not as rapid as the slope we experienced this summer. So that's the same story then when we look at the patients in hospital. Remember, the blue line is the total number of patients in our hospitals at any given time. So this time around, we peaked a little bit higher than last time. It was especially in the medical surgical, which is the orange line. But what you've seen, whereas in the summer, once we plateaued for a couple of weeks, we really had a very sharp decline, and that paralleled the decline that you saw previously in the positivity rate. Here it is a more drawn out decline, and so we're watching that with concern. We're expecting really that the number of people infected and that the progress we're making is going to take additional time this time around. And we're seeing similar numbers for the Texas Medical Center. On the top you see in the kind of purple is January, and then in the yellow you get into the month of February, and at the bottom you see the entire course of the pandemic. And again, you can see it's a smoother curve just because of the large numbers, but you can see a wider curve on that top of the second peak there. So really across all of our hospitals in the Texas Medical Center, we're all experiencing an improvement, but a slower improvement so far. I've updated you before on our use of monoclonal antibodies. We continue to be one of the leaders of this nationally. Interesting, and I think a little bit encouragingly, supporting some of the rest of the data, you see a decline actually this past 2 days in the number we've given, and that's not through any technical issues or problems we've had administering. That's a demand side of the curve, and so I see that as also a potentially positive sign, especially as we are getting out and vaccinating so many people in the highest risk groups so far. Speaking of vaccines, continues to be progress made. This is the national curve. So what you see there in the green is each day's number of vaccinations done across the United States. Now, like with all of this aggregated data, take it with a little bit of a grain of salt. There's delays. A single day may not always represent specifically that single day, but I think the trends are relevant. And in the darker lines, you see the 7-day rolling average. So you can see that 7-day rolling average is settling in around 1.25–1.3 million doses of vaccine given a day. That's a combination between first and second doses. The Biden campaign, campaigned on the fact and talked about the fact as they were transitioning about 100 million doses in 100 days. So that certainly looks achievable given where things appear to be settling out right now. And I think there is still some good news to suggest some continued increases, and I'll talk about those. This is our experience at Houston Methodist. So in the blue bars, you see first doses that we've given, and in the orange bars, you see second doses we've given. Now remember, this is entirely supply side constrained. In other words, we get vaccine in, it goes in the week we get it, and we are very efficient at doing that. So where you see ebbs and flows, that really represents the ebbs and flows of the vaccine supply that we are getting. Right now, we appear to be at a relatively sort of constant base level that I think we can rely on each week, and then occasionally we get some additional, and I'll talk about that in a second. This is an interesting week, and actually if you look at those last 2 days, Monday, Tuesday, those are actually the two highest days in total number of doses we've ever done. Both days around 6,300, 6,400. It's just that they've shifted to a lot of second doses this week as a bunch of early people who got Moderna with a 4-week interval and a bunch of people who got Pfizer with a 3-week interval, they're all sort of coming to head in the same week. Now we're pretty much an exclusive Pfizer shop other than finishing second doses with Moderna. I don't think we're going to be getting Moderna anytime soon from the government. I think we're going to continue getting more Pfizer. So this is the look at our community as a whole. And so here you now see 8 weeks worth of vaccine distribution into the greater Houston 9-county area. And you can see this past week, which is the doses that arrived 2 days ago on Monday, is a particularly banner week after a couple weeks that were slightly under 70,000 or so. So pretty much double what we were seeing those weeks. This is a one-time phenomenon. What happened is the use of vaccine for the nursing home program ended up not being as high as they had projected. A large part of that is nursing home personnel who are not getting vaccinated because the residents have, I think, largely been vaccinated. So they released about 250,000 vaccines back. And so this represents a bunch coming into the state as a whole, about half of that coming in as first doses. And then in about 3 weeks, of course, we'll get the second doses. So that resulted for the week in a doubling in the greater Houston area, and we saw a big uptick as a result as well. In the pink and red boxes, you can see the Houston Methodist allocation. Remember, in week 5, we were one of only 3 hubs, and now there are a series of hubs across greater Houston, but we continue to get very large quantities of vaccine. In fact, this week, with this very large second dose that we're doing, we are also getting by far our largest first dose combination that we've gotten. We're getting sort of the baseline that we always get, which has been ratcheting up each week. So 13,650 doses centrally that gets distributed around the system. But additionally to that, we're getting about 15,600 doses combined across Fort Bend County and Montgomery County. This is because the state this week took that extra allocation, looked for zip code or looked for counties that were lower allocation around the state and really pushed a lot of vaccine into those counties. And so we're having kind of a crazy week, honestly. We're going to do probably 55,000 plus shots across Houston Methodist. Remember, we've done about 125,000 to date. I mentioned that they've continued to expand the hubs. I think they're pretty much done expanding those. There's actually now 82 this week. Maybe a few more will trickle in, particularly in some underserved areas of the state that may not have a hub. But I think in terms of our region, the hubs are pretty much named. You can see there are 6 in Harris County and then others across the surrounding counties. All of this resulted in a really nice visit for us a couple weeks back now from Governor Abbott. He came and met with several of us. Roberta and I were there meeting with him, and then we had 4 leaders around our front lines who met with him as well. from nursing leadership who've run COVID units and ICUs to our physician who leads up the monoclonal antibody program, to Dr. Masood, who you all have seen, who heads up all of our ICUs. We had a great, about 45 plus minute conversation with him, and then he went on to do a press conference. You can see some of the quotes in the bottom right box there, but it was really rewarding, I know, for our teams who've worked so hard across Houston Methodist, and then teams across other Texas Medical Center institutions, Houston and Texas institutions, all of whom are working very hard to vaccinate. So we really big time appreciated his visit to Houston Methodist. In that visit, he pointed out that Houston Methodist has vaccinated more than any other institution in the state, and has also provided more monoclonal antibody infusions than any other institution in the state. And based on supply that's come in since then, I'm quite certain we remain in that first place position across both of those activities. I've reviewed this with you before, but I want to update it a little bit today. This is the vaccine needed to get all of Greater Houston vaccinated. So remember, there's about 7.1 million people. About 5.4 million of those are 18 and up. So there's a couple 100,000 more that are in that 16, 17 year range that also would be eligible for vaccines. So call it about 5.5 million people roughly that are eligible to be vaccinated right now. We pretty much need all of that eligible population to get vaccinated to reach herd immunity. Now, some of those could not get vaccinated. We could vaccinate some children later once this is approved in children, but until it's approved, really that is our target, and that's a pretty daunting task, obviously. When you look at the supply that's come into Greater Houston, it's really notching up, and this was a good week. But nonetheless, if you look at the individuals in that small blue bar, which is 800 plus thousand individuals who are 65 and up, another 420,000 who are in the 1A category, call that about 1.25 million people who are in that very, either the tip of the 1B or the 1A category, and we're, well less than half of that still in terms of vaccines that have come into the community for first doses. So even if we assume in that group maybe 3/4 want to get vaccinated right now, that's 900,000 to 1 million people. You've still got 400,000 people to go, and based on vaccine supply, I think we're going to go back down towards that 70 or so a week, maybe creeping up from there, maybe a little better than that. So you're still talking several weeks to get through that population before we really are able collectively to loosen things up below that age band. Across all the institutions with the Texas Medical Center, working with the city and county, I've shown you this plan before. We can do this in 180 days if the supply is there. Clearly, we're well into that 180-day period, and the supply just isn't there to get to those kinds of numbers. We would need 52,000 people or 52 vaccines done a day. So if you split that between first and second dose, call that, just for rough numbers, 25,000 first doses in a day, and we're getting about 70,000 a week. So we're getting about 40% of the supply we need to do this. Now, with some good things, that there's still nursing home that got cared for that wasn't in those numbers, and again, we had a bolus this week that's probably a one-time bonus. So we're really eagerly looking for the supply to go up, but also additional vaccines to come out. I know we'll talk about that in Dr. Sostman's remarks, as well as our Q&A area, because more vaccines will obviously help the situation significantly. In coming close to wrapping up, I want to talk about what we're doing collectively. This is across all of the institutions, really focusing on how do we distribute vaccine very equitably across the community. This is a real challenge. It's a real difficulty. Many of the populations in the areas of town that were hardest hit and are still hardest hit by COVID are also some of the most either reluctant to get vaccinated or the most difficult to reach into, particularly with a minus 70 degree vaccine. And so there's significant challenges underway with this, but a lot of purposeful time and attention and resources being put into making sure that we do this as fairly and as equitably as possible and really bring this down across our community. And then I'll end with a slide I've shown before, and I show this kind of every chance I get, which is to remind people that the vaccines are safe and effective. Get one as soon as you possibly can when it's your turn, but be patient. We still have only a small fraction of the vaccine we need. Remember, there's about 560,000 doses for about 5.5 million, that's first doses, for about 5.5 million eligible people in the greater Houston area. So we're really at only about 1 in 10 of everybody who's eligible. Now, not everybody wants one, so maybe we're at 1 in 7 or 1 in 8 right now for the people who want one, which means the majority of people still can't get the vaccine that they hope to get. So please be patient. The state is creating those prioritization systems. Recognize the side effects are going to happen. I was talking to one of our board members today who got their second vaccine yesterday and who is feeling a little punky today, but knows that it is worth it. And those side effects are mild, they're manageable. They are much better than getting the virus. Take the first vaccine you can get anywhere, anytime, and right now that's Moderna, Pfizer, or wherever you've got to go. And we'll talk about this, but when you talk about a J&J, that's going to be a grab a J&J if you can get it. Even if you perceive that the efficacy may be slightly different, get whatever you can get as soon as you can get it, and we'll sort the details out later, frankly, in terms of boosters. And even after vaccinating, please continue wearing a mask. We're in a race right now, frankly, with these variants that are coming out. We'll talk about some more of that. And we need to get vaccinated as quickly as possible, but we need to bring down the level of virus as quickly as we can so that we have fewer virus out there mutating and creating potential additional problems later. So thank you very much. I'll turn things over to Dr. Sostman, who's going to go through some of the details and some of the new information about the vaccines. Thank you.
Great. Thank you, Mark. And I'm going to update us on how we use the immune system to fight COVID. Just to remind you, there's data out there now that shows that a previous infection with COVID provides pretty darn good protection against reinfection in the 80 to 90% range. And if you do get reinfected, you're much less likely to have severe symptoms or indeed any symptoms at all. But it's not perfect. You can get reinfected, and some folks who've had prior COVID can carry levels of virus that could potentially infect other people. So the question is, can we do better than that with antibody-based treatments and vaccines? So let's talk about the antibody treatments first. As you know, Houston Methodist was one of the leaders in the country with convalescent plasma. Different people have done that treatment differently. The way we do it, works and has been confirmed by a randomized, placebo-controlled clinical trial showing results very similar to what we have found here. That really led to the development of monoclonal antibodies against COVID. 2 companies have had emergency authorization from the FDA specifically for treating early, mild to moderate COVID-19. You need to have a positive SARS-CoV-2 test, and you need to be in a high-risk group. All the common comorbidities qualify. You get about a 60 to 65% reduction in progression to disease that's severe enough to be hospitalized. Importantly, and this will come back to the issue about the mutants and the resistant strains, treatment with a single monoclonal antibody leaves about 6% resistant viruses in your system. So everybody's moving to these dual monoclonal antibody cocktails that quash the virus completely. Now, they've also done studies in people who were in the hospital already, and really not a lot of efficacy there, so it's really important to treat early. If you get a positive SARS-CoV-2 test, you're in a high-risk group, and you feel sick, you should really seek medical advice right away and get these monoclonal antibody infusions. As Mark pointed out, Houston Methodist has been a leader here, doing about 400 infusions a week, and we think this has really helped to reduce the hospitalization. There have been some recent studies, and I won't go into them in great detail. One done by the Lilly company showed that if you use monoclonal antibodies as kind of a passive immunization in long-term care facilities. It can really reduce the prevalence of symptomatic infection. Likewise, a study done by the Regeneron company showed that household contacts of a COVID-19 patient can be protected basically 100% by this kind of passive immunization approach using monoclonal antibodies. And importantly, the dual monoclonal antibody cocktail is active against some of these really common variants that are starting to pop up. So very important therapeutic modality. Turning to vaccines, this is kind of an update of a slide I've showed many times, so I'm just going to try to hit the high points. We have obviously the Pfizer and Moderna vaccines approved and in heavy use now. Probably the next one that will be approved, I would guess probably in March, will be the Johnson & Johnson vaccine. This is really good news because it's pretty easy to use. It's a single dose. There have been some different reactions to it in the news media. Some have been quite positive, some have been a little more lukewarm. And that's because the headline number here, here on the efficacy, 70-some% reduction in symptomatic illness compared with Pfizer, 95%. But if you look at the reduction in severe COVID, the stuff that's going to put you in the hospital, threaten your life, it's really just about as good as the mRNA vaccines. So it doesn't protect you against flu-like illness quite as well, but will keep you out of the hospital just about as well. Probably the next one that'll be up for approval is the AstraZeneca vaccine. My guess would be April. And then the Novavax vaccine, which will be probably closer towards the summer. And again, all three of these have a sort of similar theme. They're maybe not quite so much reduction in symptomatic illness, but pretty robust protection against severe illness. One of the common questions that we got before the show today was this whole issue, I'm vaccinated, what does that actually mean? Am I less likely to get sick? Am I just less likely to get severely sick? And can I transmit it to other people? So to answer those questions, and we can go over it again in the Q&A, you are much less likely to get sick if you're vaccinated. Anywhere from 75 to 95%, depending on the vaccine, less likely to get sick. If you do get sick and you've been vaccinated, if you're in that 5% with the Pfizer and Moderna vaccines that still did get ill, you're much less likely to get severely ill or need hospitalization. So less likely to get sick, less likely to get severely sick. The question of whether you can be an asymptomatic carrier and potentially transmit the illness to other people is still out there up in the air. The data is starting to look like that there is protection against asymptomatic carrier state and therefore protection against transmitting to other people. Early data would look like about 65% protection. Not quite as good as the protection against symptomatic disease, but still pretty good. That is early data, and I don't think we can yet rely on it. In the real world, what does this look like? Well, let's look at the data from Israel, which has the highest rate of COVID-19 vaccination in the world per population. And look at this graph over here on the right-hand side. The blue is the groups that have not yet been vaccinated. The light turquoise is the groups that now are being vaccinated. And you see, once the vaccination takes hold, all of a sudden the hospitalization rate plummets. Whereas those folks were more likely to be hospitalized than the younger population and the darker blue bar. After the vaccine is more widespread in that group, they are protected. So the real world experience looks like it is following the clinical trials. And our early studies in the Houston Methodist employee population would bear this out as well. Safety, the news media love to play up safety problems and so forth. As Mark pointed out, these reactogenic effects, the kind of flu-like symptoms, these are evidence that your innate immune system is activated and processing the vaccine. They're actually kind of a good thing. They may not feel like a good thing for 24 to 36 hours, but they're very treatable with Tylenol, Motrin, and so forth. They are not a reason not to get your second dose. They are not a reason to avoid vaccination. They're just a normal biological reaction. Pregnancy, there's really no data. There's no evidence of any kind with this vaccine or any other vaccine to suggest a risk in pregnancy. And in fact, COVID is a high risk for a bad outcome, or pregnancy is a high risk for a bad outcome with COVID. So I certainly would counsel my family members to get vaccinated. One thing we have seen that was not seen in the clinical trial is a very low rate of severe allergy anaphylactic reactions, treatable with EpiPens, and we're talking about a couple per million, as opposed to 1 in 1,000 risk of death with COVID. So basically it's kind of a no-brainer here. It's a risk that we didn't see before, but it's very, very rare. There's really nothing else documented as a severe safety problem. You'll see stuff in the news. A great example being, when they vaccinated everybody in the Norwegian nursing homes. 40 people died. Well, what they didn't tell you was that normally 400 people a week die in Norwegian nursing homes, and the rate of death after the vaccination was not increased. So a lot of stuff out there in the news media. These are quite safe vaccines. So it's good news story. What could go wrong? Probably the big concern is these viral variants. It's a normal process for viruses to mutate and to respond to selective pressure by developing different strains. The big concern here is, could they escape the monoclonal or vaccine-related antibodies? And that is a worry. The UK variant does not appear to be problematic as far as escaping antibodies. The South African variant does look like a bit more of a concern. And the question here is, can the antibodies recognize the virus? So, you might recognize this person, but this person has undergone a lot of changes since this photo was taken, and you might not recognize them as the same individual. Likewise, the spike protein, as it accumulates more and more changes, may be less and less recognizable to the antibodies. And that's really the concern. What we've seen in very, very early data is the British variant really doesn't seem to show any resistance to the antibodies. The South African variant, much more concerning. For example, the Novavax vaccine trials in England showed 86% efficacy in protecting from symptomatic disease. In South Africa, it was more like 60%. So probably we're starting to see some resistance to the vaccines. What does that mean? That means a couple of things. It means we're probably, for the next few years anyway, going to be developing annual boosters. Not that the SARS-CoV-2 virus is mutating that fast. It's slower than influenza, but there are just so many people out there walking around with COVID-19 that even a relatively stable virus is going to generate new strains. So that's probably what's in our future for the next few years. Nationally and locally, need for surveillance of these COVID mutations is quite acute. Our pathology department is doing a great job sequencing these viral genomes. But nationally, we need more efforts in this regard. And then, of course, it's winter. Please remember that, especially with these viral variants coming out, you've got to continue the physical distancing, the hand hygiene, and the masking. Really double down on this with extra care. There's a lot of talk about masks that I really don't have time to go into, but a lot of people are double masking, Tony Fauci being one of them. He got his hand slapped when he said, you should double mask, but he's sort of crept back up to, well, maybe it's a good idea. And there's dispute even within Houston Methodist as to exactly what to do about this. I will tell you that a good quality mask that fits well is really the most important thing. Spend time outdoors. We're lucky in Houston. You can go play golf instead of sitting indoors all the time, or walk in the park or whatever. Humidify your house, get some fresh air in there, get your vitamin D checked, sleep well, get your flu vaccine, and get your COVID vaccine. I can't say it any more plainly than this. Anybody who is offered the COVID vaccine and turns it down is crazy. I'll skip over this stuff about masks, and thank you for your attention.
Thank you, Dirk. You put that nice and plainly. Go get your vaccines. And I couldn't agree more. And as Dr. Sostman talked about with some of the variants, and we'll talk some more about that in the Q&A, as I said, we're in a little bit of a race against these mutations and these variants out there. And so the combination of getting everybody vaccinated as quickly as we can, but really more importantly, the combination of doing the fundamentals of bringing this virus down so we don't have the level of mutations that are happening and the level of virus that's happening out in the community are critically important right now. So with that, I'm going to switch over to Dr. Roberta Schwartz. Dr. Schwartz is our Executive Vice President and Chief Innovation Officer, also has served as Incident Commander for going on a year now, which has been, I'm sure, the longest year of her life, along with many of the rest of us. And she's going to talk specifics about some of the Houston Methodist vaccine distribution plan, and then we're going to have a lot of time for your questions. Thank you.
So it's a pleasure to be with you today, and I know this is probably the most pressing issue on everybody's mind who's on this call, which is how do I get my vaccine? When do I get my vaccine? When does my family get vaccinated? And when does everyone get to the point of that herd immunity? Which will really be absolutely wonderful. So let me kind of back up and talk about a little bit about kind of that state program, which is this hub program. The state has really focused on large vaccination sites that can vaccinate over 1,000 vaccines a day. To their preference, it's really over 2,000 vaccines a day. And we feel very blessed to be a part of the public health effort for the state of Texas. As a part of our vaccination hub effort, we currently have 7 sites that we're operating as vaccination locations. They operate mainly Monday through Friday, 7 to 7, as well as Saturday from 8 to 12. We made a decision early on, which is that we were going to have walk-in sites and do what we called larger sites, because we really wanted to lay eyes on those patients kind of in front of you, as well as monitor the patients kind of as we could see them. You'll find that this is a little bit different than other sites are doing, and we appreciate it. I think you're going to have lots of different efforts, everything from in people's homes to drive-up sites like people are having in Houston, and all of them have incredible merit. So we've really focused our effort around these 7 sites, and you'll see right now we're able to kind of scale these sites up to about 7,000 vaccines a day, and certainly in this week where we're providing 55,000 vaccines this week, this is a monumental effort. Just to give you an idea, this about doubles the amount of people that we were seeing in our physicians' offices on a daily basis. So you can imagine scaling any one of your businesses to twice the size in the period of about 6 weeks is pretty incredible. And I'm incredibly proud of the effort that has put in it in our physician organization, in our pharmacy, in our laboratories, in each part of the organization that this has taken. So you can see this is a crazy week. This is the week where second doses of Pfizer met up with second doses of Moderna, because one's at 28 days and one's at 21 days, as well as the state providing us with 30,000 new doses of vaccine. So really those efforts to get all of those people vaccinated means that we are running through in all of our site anywhere from 1,000 patients to 5,000 patients a day. So our Herculean task. We are a vaccination hub, and we have committed to the state that we will vaccinate a large-scale part of the population. So the largest hubs at this point in time are us, the city, and the county. Memorial Hermann is coming up as a large hub, St. Luke's, as well as a number of different entities that are starting to come up. And I was even hearing on the news this morning that we're going to start to shortly see the pharmacies kind of come online, which will really be a wonderful part of the vaccine effort. It is going to take all of us. I think, as you heard from Dr. Boom, getting to that point of herd immunity is going to take everyone really being involved. So where are we, and where are you in line, and where do you get your vaccine? That's probably, when I looked at the questions from everybody, this is probably where we're focused. So 1A was healthcare workers, as well as nursing homes, and those people in acute care living facilities. And so I would say to you that we are a good way through the 1A population, but that continues. Every week we find more and more, whether it's physician office staff or healthcare workers or therapists that really haven't been vaccinated, and we continue at a rate of about 500 plus 1A population every week. The second part is 1B. And 1B, we've subdivided into 3 different groups to kind of be able to chunk and make appointments in a reasonable period of time. So we started with the 75 plus. And while there are many more 75-year-olds and above that have yet to be vaccinated, we're seeing fewer and fewer of them that we're hearing about. We catch them as we can, but that haven't at least made some offer of vaccination from the city, from the county. And now we really are starting to recognize that we're going to have to reach into populations and kind of grab those people rather than having them reach out and find us. The second part is the 65 plus. And we began reaching out to the 65 plus starting last week with 65 plus year olds that have 3 or more comorbidities. We began 2 or more comorbidities this week, and we'll have those with 1 comorbidity starting next week. Then we have to get to our third group, which is the 1Bs that are younger than 65, but that have medical conditions. And I would tell you that we're probably a few weeks off from getting to this population and inviting them into start doing their appointments. So I'm going to ask you at the end, this continued patience, which I know is very hard, is really very important. In addition, when we are a vaccine hub, we have to invite not only Methodist patients to come and vaccinate at our location, but also the public. And we are reaching out far and wide. We are partnering with FQHCs, with other healthcare centers, with Baylor, with other groups to basically reach into populations and make sure that we are capturing all of the zip codes and all of the populations that touch Houston so that we can achieve not only herd immunity in a population, but in all of the populations that Houston touches, because it really is important that we get everywhere as quickly as we can. So this public reach out effort is very important. Now, I will tell you, the minute we put out a sign up form, within about 18 hours, we'll have about 20,000 people sign up for their vaccine. So we then reach in and qualify those individuals for age, for condition, and really want to reach out and get those people in who meet the same criteria that our population is reaching that are in our current Houston Methodist databases. So you can see we are actually getting to a huge amount of people as quickly as we can. I was talking to a center of our size in New York City yesterday. They've really only reached about 50,000 people, where we're kind of at much higher levels as quickly as we can. Week by week, you'll see that the population of people that we are reaching is changing. So when we were talking back in December, when we began this population, we were reaching primarily 1A and our employees. And today, as we look at that same kind of number of vaccinations that we're doing, we are reaching far more in the elderly population, which is really the group that we're targeting. And I'm very proud to look back and recognizing that we are getting to that correct population that we targeted. You can see these numbers growing week by week, and it's exciting to note that the number of vaccines and the number of vaccine hubs are growing in the city and in the state. We are getting huge amounts of compliments for the efforts that we are doing. Now, I know for some people they're concerned. They're concerned that there are lines getting in. We're doing that primarily to distance people. We're getting concerns, and we're improving these efforts week after week, whether it's more wheelchairs, whether it's more vaccination stations, whether it is more people to direct traffic or get people in and out quickly. We're improving these efforts, and I hope that you all will bear with us, but we thank you, honestly. These compliments kind of keep us going. That staff is working so very hard. There are people who are sleeping only a few hours a night because they're staying till late in the night, and they're waking up first thing in the morning to make sure these efforts continue going. So we love your compliments, and we hope you'll keep them coming to keep the spirit of our folks up. And we have gratitude walls up in most places where we're working. So how can you help us? Please be patient. There's only so much inventory of vaccine at this point in time. We cannot accommodate walk-ins. We cannot accommodate huge amounts on that wait list at the end of the day. We are not vaccinating inpatients, and that's a whole different lecture that I'll be happy to get into at different points in time. But there's lots of things that we cannot just accommodate right now as we move through this very quickly. So we'll keep you updated as we move to more and more groups. These are places that you can turn to for information on our vaccine efforts. And with that, I'm going to turn it back over to Dr. Boom to answer questions, and I hope I picked up a few of mine along the way.
You did. Thank you, Roberta, and thank you to you and the team for the hard work. As she mentioned, it is a prodigious amount of work to be vaccinating the number of individuals that we are doing across the system right now. So kudos to you and your team. The most common compliments I'm getting is it feels like going to Disney World. It's so organized every step of the way. Unfortunately, like Disney World, there's some lines as well. But seriously, most people can be in and out, including a waiting period in well under an hour. which I think, given that we literally will have thousands of people come through every day, I'm proud of, and I'm proud of the team. So thank you for the great work. So we got a ton of questions from y'all this week, and we've left lots of time purposefully to get to these questions. We'll have covered some of these, but some of the ones that often get asked, and I'm asked repeatedly, and others are asked repeatedly every time we speak about this, I want to kind of double down and reinforce. So this is one of those slides, Dr. Sostman, really a series of different ways of asking that question of what exactly does the vaccine do? Am I truly immune? Can I give it to somebody else? Why are we talking about wearing masks for a while, and all those kinds of questions here?
Yeah, so I think we can all answer this question, but I'll start off. You're really asking, what does it mean to be vaccinated? What does it do for me and my family? So first off, it makes it much, much less likely that you will get sick from COVID-19. For the vaccines we have now, it's about 95% less likely to get sick from COVID-19. If you pick that 5% lottery ticket and you still get ill, you're much less likely to be severely ill. So you're less likely to get sick, you're less likely to get very sick. The question about whether you can carry it around and infect other people is not answered definitively as yet. I think the evidence is starting to emerge that you have some pretty significant degree of protection against carrying COVID-19 but being asymptomatic, and therefore being able to spread it unknowingly to vulnerable people. But don't relax for that reason. First of all, this data is very preliminary. It could be wrong. Secondly, it's not going to be 100%. There's still going to be some percentage of getting sick. There's still going to be some percentage of having the carrier state. So really, it's just so important to keep physical distancing, keep washing your hands, and keep masking effectively.
Perfect. Well, thank you, Dirk. Another question here, kind of along the same veins, but they talk about 95% protection, 94 to 95% with the Pfizer and Moderna studies. What does that actually mean? Can you define exactly how that number is calculated?
Well, the person who asked the question had it right. It means that of the group that's vaccinated, only 5% are going to get COVID. Of those 5%, the evidence is that you will tend to get a lighter case. So that's correct. And as I said, the updated data on once you're vaccinated, can you still be a carrier, suggests that yes, you can, but it's pretty unlikely. But again, you can't rely on that updated data quite yet.
So, put another way, roughly, let's say, just for sake of math, I don't remember the exact numbers off the top of my head, but if you vaccinated 25,000 people and you had a control group of 25,000 people and you're blinded, right? At that point, 50,000 people have gotten vaccinated with either a sham vaccine or the real thing, and then you waited for people to get sick and for a certain count to get there. So I'm just making up numbers again here, but say you waited for 300 people to get sick, and then 300 people had had symptomatic COVID. When you then drilled down into those 300 people, 15 of them basically were people who had gotten the vaccine, and the other 285 of those people were people who had gotten the sham. And so that's where you see those kinds of efficacy numbers coming through, which is really impressive. But really importantly, to pick up on something Dr. Sostman said earlier, because it'll come up again, and we're going to make this point several times. Again, going off right now of press release data, we've not seen the actual studies yet from J&J, but based on press release data, it was close to 100% effective in preventing death and hospitalization. So even if people were getting sick, it's kind of like the flu shot, right? Every year, the flu shot we know might only be 60% effective at preventing somebody from getting the flu altogether. But we also know that if you get the flu, you're far less likely to get severely ill. And that's ultimately the most important thing for us to get rid of death from this disease. Obviously, we'd like to get to herd immunity and extinguish this altogether. But realistically, with mutations coming and other things, that's probably not going to be happening this year. And with reluctance to get vaccinated, what we can do is extinguish death and then get to a point in time where we have a booster series along the way. Probably that keeps things going.
If we can't eradicate people getting the sniffles, it's not the worst thing in the world. If we keep them out of the hospital and we keep them out of the graveyard, that's much more important.
Right, exactly. I mean, if we knew that we could go back to life, and some people might get COVID and be minorly ill and they've had the vaccine and really not much risk of being severely ill, the hospitals would be freed up, society would be much, much more back to normal. So I think that's probably a more realistic expectation, but it's unfortunately still a ways away. Okay, so I'll take this one here, which is the new variants, and are we going to need new lockdowns? And Dr. Sostman has talked about some of this already, and these variants are of significant concern, quite frankly. So remember, there's 3 major variants that have emerged right now. There will be others. And let me start by the fundamental fact that the more virus that is there in people's bodies somewhere around the world, every person who has it's basically a little little virus factory, and you're going to have a base rate of mutations, and the more that's out there, the more likely that more mutations will happen just numerically, and eventually some of those mutations take hold. So the first and fundamental issue is we've got to get the rate of virus down in the community. So we're paying the price, frankly, for the fact that this has spiraled out of control really around the world this fall and into this winter, and now seeing those variants. The science is very inconclusive right now about the variants, as Dr. Sostman talked about. It looks like the UK variant, which pretty much took over the spread in the UK, is more infectious, so it's more likely to spread and more quickly. So that's a definite concern coming up, is we could see another uptick as something becomes more likely to spread quickly. But it looks like it most likely is covered by previous immunity reasonably well. It looks like it's most likely covered by the vaccines at a pretty effective level. Then you have the South African variant, and some of the initial data is concerning there, quite frankly. One of the reasons we may be seeing lesser effectiveness or efficacy for Johnson & Johnson and for Novavax, as you look at a couple of these, may simply be it's a different set of viruses that they're treating out in the world as well. That could be part of it. But it does look like there's early signal to suggest that it's still preventing serious illness and death. So I think there's still a lot of reason for hope. Far from certain at this point in terms of the data, but reason for some cautious optimism and hope that at least it will prevent severe illness, even if we might see some reinfections or second infections happening. So still see 2 critical things: is plow forward with protection, and so do the things we know work to bring this down, and plow forward with getting people vaccinated as quickly as possible. Realistically, aggressive lockdowns, I mean, let's face it, folks, they're not going to happen. It's not going to happen in this country. I'm not suggesting it should be happening at this point. This is one of those things I think we've seen over and over. If people do all the right things together, actually we can avoid the need for those kinds of things. Frankly, from a school perspective, there's not great evidence to suggest that schools have been a massive problem in the United States. Some schools have thought, sorry for the pun, but some schools have thought that they actually may be a safer, more structured environment for many of our children a lot of the day than they would be if they were not in the school setting. And so I don't think the data suggests that at this point, and realistically, I don't think that's going to happen.
Yeah, likewise. And transmission from school children to adults doesn't seem to be a big issue. I know my son's going to school in Europe, and they're in session. They all wear masks and all this kind of stuff, but they've been in session for months, and it doesn't seem to be causing a problem. So I really agree with Mark. Number one, opening school is much more important than opening bars, And schools are much less risky than bars. So, really important that we get kids back to school. And I don't see anything in the data that suggests we should not move forward with that.
So, moving on to the next question, we've both just covered a lot of this, but I want to just focus on the last little part you see here, is what do you think seeing these mutations means practically going forward? Does this, we would be asked over the last few months, oftentimes, are we going to need annual boosters? All those kinds of questions. I think we're starting to have a pretty good glimpse at what we would predict the future will look like with that.
Yeah, so I think the near-term future for the next 3 to 4 years, 3 to 5 years, is going to be one of annual boosters, because as Marc pointed out, there's so many people worldwide who are infected with this virus and generating, different mutations all the time. Even after we get it under control in America, there's still going to be infections rampaging in other countries. And we can't shut the borders, so these new strains are going to be here constantly. So I think you're going to have a world of getting a COVID booster with your flu shot every year. I'd say in the intermediate term, 5 to 20 years, it may not be every year. Maybe it'll be every few years. And then longer term, once everybody in the world has been vaccinated and it's not a pandemic anymore, and the first time human beings see this virus is when they're, toddlers who do just great with this, it's probably just going to become like the common cold. And people will get exposed to it as kids, and it'll just be another endemic virus that we deal with. But for the next few years, I think we're going to be dealing with annual boosters.
Yeah, I think that's most likely. And so talk a little bit about developing the annual boosters. We don't know everything about that yet, but clearly the flu, there's a process every year where they try to identify the next strains, and there's sort of a blanket approval, and they move forward and are able to do that. Talk about the process, particularly right now with the mRNA vaccines, which last year, if you remember, very rapidly, within a matter of just weeks, had the actual vaccine prepared. Then it was a matter of studying it. How do you think that goes forward for those boosters?
Well, I think it'll be faster and more effective than we do with the flu, because with the flu vaccine, they kind of have to guess what they're going to be boosting against pretty far in advance. With the RNA vaccines and also the viral vector vaccines like J&J or AstraZeneca, really the only thing you have to change is the genetic payload that the vaccine carries. Because remember, very simplified, the vaccine is a carrier and a genetic payload that gives your body instructions to produce the antigen. So they can change the genetic information in probably about 6 weeks, and have a vaccine that could be administered and updated against the latest and greatest mutant. Trying it out and getting the FDA and the other regulatory bodies comfortable with it's probably going to take more than that, but I think it'll be a matter of months to get a pretty effective, pretty tailored booster available.
Let's hope so. And obviously there'll be work to be done on the regulatory side to expedite that, yeah. and also to analogize really to what we do with the flu, where we are able to do that. I think once we get to full authorization as opposed to emergency use, some of those things will be more likely as well. So let me, the question here, and we've touched on this, but let's dive a little deeper. So the efficacy for Johnson & Johnson, let's go through that one because we think that's the next most likely to be released. It just flat out isn't as good as the others, right, when you look at the numbers. But you drew that distinction between, just getting ill versus getting severely ill. And then pragmatically, there's no way we can get enough people vaccinated with Moderna and Pfizer fast enough, so we have to use that, correct? And so talk a little bit about how you would look at that, and ask directly, if you had a choice, which one would you take?
Well, I would take the first one that somebody offered me. If somebody was giving me, 3 syringes full of vaccine, I think the Pfizer and Moderna are, just close your eyes and pick one. I would probably pick one of those over the J&J, recognizing that you're going to have to come back for the booster dose of the same vaccine. It's going to be more inconvenient. And I think the choice there is, as Dr. Boehm said, do you want convenience and a somewhat higher chance of getting a kind of very mild flu-like illness, or do you want inconvenience and more chance of not getting a cold? In terms of choosing between the 3 for protecting you from getting in the hospital or dying, they're really pretty much the same.
So fundamentally, I think we're saying the same thing. Just go get a vaccine. Whatever comes available, we can sort out some of those differences later. And frankly, if the delta on severe disease isn't very significant, which it appears it isn't, again, with press release data so far, fundamentally what really matters in being protected is going to be close to indifferent, I think, among the vaccines based on what we know so far.
Absolutely. Just get yourself protected as soon as you can. And 8 months from now, when the boosters are available, if you always had a hankering to get that Moderna vaccine, well, go get the Moderna booster. Yeah.
Exactly. So a lot of questions about second doses. You'll see 3 different versions of that actually coming in today as we speak. There's another question about the Biden administration and second doses. So let me talk briefly about that whole topic. First off, we've had 0 issues getting second vaccines into our supply chain. So on Mondays, we get our first doses, and on Wednesdays, 3 weeks later, or from Moderna, which we're now not really, after this next week, we will be done with all our second vaccines of Moderna, we get those vaccines in. So far so good. It's worked very effectively. We've had 0 issues in getting that to individuals. They're exactly the same, so they're interchangeable. So from our standpoint, it's just a supply chain issue of, we don't necessarily mark one as first dose or second dose and say you only use it for first or second. We just make sure we have enough on hand as we track that. They're the same doses. There's nothing different about that. In terms of the window, it is 21 days for Pfizer, and it is 28 days for Moderna, but that's not carved in stone. In fact, the CDC's given several week guidance around that timing. Practically and most likely, but not yet backed up by the data, the window is probably even far longer than that based on our experience with every other vaccine we use. So for example, if somebody needs their Shingrix or somebody needs their hepatitis B in my primary care office and they don't show up in the recommended window and they're 2, 3, 4 months later, the recommendation is give them the next dose and move on. And so I think practically speaking, it's not a real big deal to be a week or 2 late. We just don't have the data yet to say whether it's definitely okay to be 2 months late or 3 months late. And the question that came in today as we're speaking was about national discussions about getting more people vaccinated sooner with a first dose and holding off on the second dose. That's a strategy the UK decided to do early on. Again, it's not backed up in the data. I'd say there is some common sense to support it, but not backed up in the data. So the more conservative approach has been the one that our country and most countries have followed. I think that dialogue is happening again right now, honestly, because of this issue of the mutations and the variants, because of a thought that, hey, let's get everybody partially vaccinated to start and get through the population more quickly. I've not seen any credible data on that, no definite change, anything like that. Obviously, we'll continue to watch that closely, but not aware of any formal change coming down the pike. But there are some pretty loud voices advocating for that around the country right now. Quick answer to the second vaccine. Basically 1 week after the second vaccine in both of the studies is the time frame that they were measuring people, and so that's a point where you can feel confident you are fully protected. Okay, so we got a series of questions here, which are practical, right? Hey, I've been vaccinated now. Surely life can get a little better after I've been vaccinated. And I think surely it can. But there's a couple things I think to keep in mind. There's, have you been vaccinated, and have you gotten fully through the period of time where the vaccines are effective? Because otherwise it is a very false sense of security. That's one thing. Second thing is, remember, nothing is 100% effective. So there's still a risk, as we've been talking about. A third thing, of course, is who are you interacting with, and are they vaccinated, and where are they in their time frame? And then the last thing is, what's the general level of virus in the community, right? When the virus gets to low levels, things are far safer in general, and then if you layer vaccination on top, they're way safer. When the virus is still at really high levels like they are today, even vaccinated, it's a little bit of a crapshoot. So I would urge some continued caution, even for vaccinated people, for several more weeks while we bring this back down to levels like we saw back in September, which we can do. We've done this before without vaccines. When you get to that point, no question, I think you can start to do some things that are common sense. So having two couples, having a set of couples over to dinner and everybody's fully vaccinated, it's not going to be zero risk, but it's going to be far, far lower risk than it is today. I think you can safely go to Costco or Home Depot today if you're wearing a mask and you put precautions in place, but it'll obviously be even safer. Visiting family members or family members going to visit. The conversation I had with my parents the other day was, come April, most likely it makes sense for them to get on a plane and visit my brother in California. Most likely they're going to be vaccinated. The numbers will be down. Now, if the numbers don't go down and we're dealing with a big surge, I'm going to be telling them, no, don't do that. But probably that's fine. I personally have not gone to a restaurant yet. I answered this the other day. I think I ended up on the news with it, with a town hall we did. Frankly, because I think the virus is still at too high of a level out in the community, and I think it's common courtesy, and I think restaurants are just, frankly, one of the least safe activities because you have to be unmasked to eat and drink. It just obviously is a reality. But I think as we bring the numbers down, as you're vaccinated, a restaurant is clearly a possibility. I would anticipate within several weeks, assuming that we get numbers down, Julie and I will probably at some point say, yeah, it's time, but we still are holding off on that right now. We'll still feel more comfortable outdoors, so temperature and other things are coming up with all of that. The next question here is about documentation. If I pull my wallet out, you'll find my card. I'm going to keep it with me. Obviously, if you come through Houston Methodist, you can have an app and you can get into your My Methodist, My Chart app and look at that. But I think it would make sense, make a copy of it, take a photo of it, have something with you. I don't see any situation where everybody's checking it at the present time, but clearly we're going to see this start to be a requirement in certain parts, right? Coming back into the country, we already know there's a requirement for a test. Well, the next obvious step is going to be a requirement for a test or a vaccine. You're going to see that for airplanes. You're going to see that considered for many other places around the community as well. Okay, Dirk, talking about any sort of somebody who has more of a reaction to the first shot. Should they get a second shot? What are the things that might happen with a first shot that would preclude really getting a second shot?
Well, somebody who has a severe reaction, like a severe allergic reaction, hives, difficulty breathing, drop in blood pressure, basically anaphylaxis, you should certainly not get the second shot. Do not get the second shot if you have a severe allergic reaction to the first one. If the issue is that your reactogenic effects were worse than average, your fever was worse than average, you took to your bed. Personally, the CDC would tell you, and I would tell you, you should still get the second shot. You may wish, if you have, let's say, heart disease or some severe comorbidity, you might want to talk to your doctor first. I think this would be a case where you might want to pre-medicate yourself with Tylenol or Motrin before you get the second shot. We normally do not recommend that. We say don't take it before you get vaccinated. Take it if you get a fever and you feel uncomfortable. If you had a really high fever and you felt really, really terrible after your first shot, that would be a case where I might pre-medicate, but I would still get the second shot.
Thank you. So talk about the risk of anaphylaxis. That's really the only significant risk that we have seen there. And when I say significant, I mean meaningful, something bad happening, but its rate is actually extremely low.
The data, so, there have been about, call it 30 million shots given in America, something like that. Is that
approximately?
And so that we got a pretty good database now, and the Moderna vaccine is 2.5 anaphylactic reactions per million. The Pfizer vaccine is 6.2 anaphylactic reactions per million. So it's really, really rare. I mean, I don't have, Mark's great at this kind of stuff, but you probably have a great analogy for,
Well, you're a good straight man, because I was just going to give you some numbers. So put it in context, right? So let's take the high number. 6 out of 1 million people, so 1 in 160,000 approximately, might have an anaphylactic reaction, which is readily treatable with an EpiPen,
right,
which no one has died from. Most patients go home in a couple hours if that happens around the country, or maybe stay overnight quickly. So really unusual, right? And no other real significant untoward effects, no deaths, etc. Your risk of dying in the United States right now, we've had, whatever it is, 440,000 Americans have died from this over a population, let's call it 330 million. So roughly let's say 1 in 800 people. So you've had a 1 in 800 chance as an American this year of dying from COVID at this point. That doesn't include all the people who got hospitalized, et cetera, et cetera. And really that understates the risk for many people who are watching today, because don't forget, pretty much nobody's dying as children. Very few people are dying as 20, 30, 40-year-olds, but it starts going up significantly. So if you're older, your risk has been way higher than that as an American and around the world. And so the risk of some, hypothetical something from vaccines is orders and orders of magnitude lower than the risk from the virus. It's a no-brainer from my perspective.
And this is why I said, if you can get the vaccine and you don't take it, you're crazy, because the news media loves to focus on, this very unfortunate case of the doctor in Florida who developed this bleeding disorder. And it's probably not related to the vaccine, although it was temporarily related. But even if it were, so a 1 in 30 million chance of dying from this, as opposed to a 1 in 800 chance of dying from COVID, you just have to actually look at the real odds. I mean, I would say, so here's the analogy I would come up with. Your chance of getting an anaphylactic reaction, and the golfers in the audience will relate to this. From getting a COVID vaccine is about the same chance as getting struck by lightning on the golf course if you're holding up a 1-iron, because everybody knows God can't hit a 1-iron.
All right, the drum roll happened there for that. Well, thank you for that. Let's talk about pregnancy. This is a big topic, and we've talked about this here before. And I've gotten emails from some of y'all positive emails about some of the advice we'd given. But talk about what we know about pregnancy, what the societies are saying. I think since we had the last talk, the WHO kind of weighed in, which frustrated a lot of our societies because it was kind of opposite of what the societies were saying. So talk about that whole topic.
Yeah. The American College of OBGYN and the Society for Maternal Fetal Medicine, which are the two big, societies here in the U.S. that are experts in pregnancy and delivery, see no reason for pregnant women not to get vaccinated. They do not see any safety risk. It is clear that although the absolute numbers are low, pregnant women are a risk group for severe COVID. They're in the CDC's list of high-risk conditions. So the risk-benefit clearly is in favor of getting vaccinated if you're pregnant. Clearly, a pregnant woman should speak to her physician and think it over, but to me the data really favors getting vaccinated. Just like with every other vaccine, pregnant women are recommended to get fully vaccinated if they're pregnant. There's also the potential. Clearly, the protective antibodies cross the placenta. That's just been shown. So the protection of the baby by passive immunization is another factor. I don't know of any data on antibodies crossing into breast milk, but other antibodies do, and it probably protects the newborn. So there's no data on it, but the logic would support getting vaccinated.
Well, thank you. And that's been consistent advice you're hearing from all of our OB-GYNs, those societies, us as well. The WHO came in and sort of gave some conflicting advice, and actually they walked it back, and the societies in the U.S. actually put out essentially a very strong statement disagreeing with that and continuing, in effect, to say there should be no obstacles whatsoever to a woman who wants to be vaccinated, who's pregnant, from getting vaccine, and then encouraging each of them to talk with their physicians. I can tell you, if this was my daughter, I would be telling her, I think you should get vaccinated. The risk peripartum, in that last trimester, kind of around birth, is not insignificant. And we've unfortunately had a fair number of very, very ill young moms here at one of our hospitals, cared for during the time, of late pregnancy into postpartum period. It is a risky time, and it can be prevented.
And the original WHO statement was just this very sort of academic, pedantic, well, there's no data, so we can't recommend it. They weren't saying, it's bad, don't do it. They were saying, well, we don't want to be responsible. And our societies here in America thought that this was what really was very irresponsible, yep. Which I agree.
Okay, well, a quick question and answer. Pain relievers, Benadryl, Tylenol around taking the vaccine. What do you recommend?
Perfectly fine to take them if you get some side effects. You get, you feel punky, you get a fever. We don't recommend doing Tylenol. We don't recommend Benadryl before receiving the vaccine at all, or if you get side effects. It's not related. But we don't recommend taking Tylenol or Motrin before receiving the vaccine. Probably doesn't make a difference, but there is some data out there in children that pre-medication might reduce the development of immunity. Probably doesn't translate to the adults, but why take a chance? So don't take it beforehand, but it's fine to take it if you get side effects.
Exactly, and really for the vast majority of people, a little bit of Tylenol works wonders, plus a little bit of rest if you're feeling lousy that next day after a vaccine. Okay, so let's talk a little bit about how do we convince people who are afraid to get the vaccine to receive it, because that's clearly what we're all doing.
You give them Mark Boom's cell phone number.
I'll call him and nag him. This is a real issue, right? So right now, what we're all talking about for most of today is please be patient. Way more people wanting vaccine than we have supply for. And, we know that this whole paradigm is going to flip 180 degrees on us, at some point, depending on, supply of vaccine in the next 2, 3, 4 months, where really to do what we need to do societally, we're going to need to get more people vaccinated, yet you're going to have a bunch of reluctant people who don't want to get vaccinated at that point. So, I think this is one of those things that, there is the whole array of issues from simple low medical literacy to misunderstanding of information to just general mistrust, to not digging into the data, to actively resisting or actively seeking out and finding misinformation that's out there. And unfortunately, it runs that whole spectrum. I'm an optimist. I think we can get most people that should be there to there. But the reality is, convincing a skeptical 25-year-old to get the vaccine when he or she says, hey, I'm not going to get that sick and I'm not going to worry about other people, they can go get vaccinated, that's a real challenge. And it is a problem we have societally. We have this issue around childhood vaccinations. Unfortunately, if you look back at the last century, and you look at why did death rates go down so much and survival increase so much during the 20th century, first and foremost was potable water and the ability, really to have clean, safe water. But after that, you're really talking about vaccines, and then you're talking about, other tactics against infectious disease, particularly antibiotics. These are one of the wonders of modern medicine, uniformly, and we are now, unfortunately, societally taking them for granted. I'm hopeful that this situation actually helps push the tide back the way it should go and have people see that, but it's going to take a lot of work. So it is consistent education, it is consistent messaging, it is peer pressure, it is incentives, it is sticks, it is carrots. I mean, it is all of the above, and certainly even in our own employee population, we're using every single one of those mechanisms and methods to move this forward. But this is going to be something societally that we all need to work together. To me, at the end of the day, it's a social compact to protect each other. And frankly, without doing this, we're not going to get past the misery that this past year has been. We have to together get to a critical mass. It may not be that true herd immunity where we extinguish the virus, but effective herd immunity between people who've had it and then people who've been vaccinated, to where we don't have hospitals bulging, to where we don't have to change all of the issues that are happening in society, and we can go back to football games and we can go back to baseball games and we can do all the different things we want to do in the future. So this is a consistent effort, and I think we all need to work within our social circles, within our influence circles, as leaders in the community, as business leaders, as faith leaders, as many others, to continue to convince people to move forward. Okay, Roberta, I've been keeping you quiet over there. So I've got a couple questions now for you. So J&J, what do we know about that? Is it something Methodist is going to get? Are we going to be administering that?
So we do expect that J&J probably, I'm guessing, will go to the FDA here within the next couple of weeks. If it follows along the trail that all the other vaccines have followed, we should see that at the very end of February, beginning of March, and that will start to be shipped. We don't expect at the beginning that it will be shipped to Houston Methodist. I would expect that this will go to primary care offices, this will go to pharmacies, this will go to supermarket chains, this will go to others out in the community. And we will continue to be primarily a Pfizer shop because we've proven that we can take care of the complexity of a vaccine like Pfizer. Now, that being said, there are places where I think, whether it's our corporate wellness efforts or it's our community efforts that we work on with FQHCs and various community and wellness fairs and other types of things, that J&J would be particularly effective for, because it's the one and done. You get one shot and you're kind of completed with this vaccine course of treatment. So I think that we will look to see whether or not we can get a hold of some J&J at some point for those efforts, but those would be very specific type of campaigns.
Yeah, I would completely agree. I think, this is all a guess right now, right? But I would guess that in the early days, we're not going to see a lot, or if any, J&J, because there's so many distribution channels that have not really been getting filled up with vaccine, and it makes so much sense in a pharmacy, it makes so much sense in a primary care office, it makes so much sense for a community drive or a church-based vaccine, or a school-based or university-based or many other employer-based efforts. I'm hopeful that as things move along, we might get some, though, because there will be some specific needs. Now, the one caveat I'll put there is we have a large group of physicians, both employed and in private practice. I could see a scenario where they may be part of that distribution. So stay tuned. We'll know more, hopefully in the next few weeks. I hope sooner rather than later. Okay, so whole bunch of questions. You already touched on some of this, but I think it bears some repeating. Polish up your crystal ball. We're working on our 1B older patients. When do we get to some 1B younger patients? And let me preface that by saying the reason we chose to go in subsets of 1B really is because it was such a massive number. It would have just been a crazy free-for-all. But really mostly because we are committed to having the most impact from the vaccine for the community as fast as we can. And we know that 3/4 of people who have died in our hospitals from COVID approximately are 65 and up. So we knew if we could tackle that population first, we can already change this course of the disease so significantly. So talk some more about the timing and when we get to others.
So I'll intersperse this with some of the data that actually came out of the state today on a call at noontime. So it's kind of perfect time to have this town hall, which is that if you think about the month of January, we really focused on our 1A population as well as the 75 and above. Some 65 and above, but primarily the 75 and above. In the month of February, I think we're very focused on those between 65 and 75, as well as continuing on. The state reported that of the million people that are above the age of 75, they believe that about 350,000 of them have been vaccinated. Now, again, not everyone's going to want it on that front end. And if you figure that 50% of people at the beginning will want it, we've gotten to about 35%. So we've got about 15% left that are really clamoring that we need to find and root out. But I think the month of February is going to really be about that 65 to 74. And they estimate that there are about 3 million people in that age range that we have to vaccinate statewide. And get to. So you're looking at kind of that double the number. The good news is there's more vaccine coming in and more hub sites available to get to them. And so really we're looking at that month of February. I think we get to that rest of the 1B group then in March. I think that's really what I would say in my crystal ball we're kind of targeting, which means that if you then look at the general population that really don't have one of those conditions, you're looking at about April or so. And while that seems like so far away, people are saying to me, do you think I can take my vacation by the summer? Will I have it by the summer? Yes, I actually think you will. I'm going bullish on that, and I think that you will have that vaccine by the summer. And then also this question of, will my kid be able to get it before college in the fall? And I think the answer to that is yes. I actually think that it will actually be a requirement to go to campuses that your child is vaccinated, and if they aren't, then I think the colleges will be providing that for the students that haven't been able to get it, because I think that that will be essential for them operating. We're hearing some, I started to hear, I have a college kid who's saying, hey, I'm hearing some things about virtual from the fall, and I was like, is that convenience? Because I actually think that most of the kids will be vaccinated that are, again, above that age range. And don't forget, Pfizer is down to 16, but Moderna is only down to 18. And so we don't know when in the summer they'll release studies for slightly younger age groups. And I haven't seen the J&J data to that level yet to know what they're going to go down to yet. So I hope that it kind of gives you my crystal ball. I don't know, Mark, if yours is any different.
That's very, very helpful. And to pick up just on that thread, you just were starting there as you talked about college kids and then younger, because we get asked this question all the time about what about children? When will we see this approved? And none of us know that exactly. What we do know is the way these things work is they march down in age. So you'll probably see something like a 12 to 16 or a 12 to 17 age group, depending on the vaccine that gets released next. I think it's a fair bet to say they should have data by the summer. And so I think those teenage children, or just preteen into teenage, probably will have access to vaccine from a trial basis, and probably from a practical basis as well before the fall. But that's a bet right now. That's not a definite. That next age group of kind of 5 to 11, 5 to 12, less certain, although I have heard some predictions that probably by school it's achievable. I think younger than that, you're not gonna see that anytime in the near future. So we'll cross our fingers for that, because obviously that would be nice to have as well. People have asked me, would I vaccinate my kids? I have a 25-year-old who's a medical student. She's vaccinated. I have a 20-year-old college student. He isn't going to be vaccinated for a long time, but like Roberta, I think he may be vaccinated before he goes back to school. And I, frankly, if I were getting to make the decisions at his university, I'd be saying, to come back and on campus and be a college student, you're going to have to be vaccinated if you want to do that. And then I have a 15-year-old who's not eligible for vaccine, and we've been basically trying to get her in a trial. We still haven't succeeded in that, but that's how confident I am in the vaccines as we look at that. Okay, another question I get asked all the time, Roberta, is, okay, my husband, my wife, they're sick, my child is sick. I'm the caregiver. Shouldn't I be at a higher priority, and can't I get the vaccine sooner? And obviously, people generally aren't going to like the answer, the way the state's defined it, but go ahead and tackle that one. So.
Yeah, the state's been pretty specific on this answer, and the answer is no. So what they've said to us is that you are allowed to stay in this lane at this point in time, and that lane is defined as the 1B population. And if you care for or surround the 1B population, you do not necessarily fit into that 1B population. Some people come back to us and say, well, home health care workers are defined as 1A, so shouldn't I count as a 1A person? And while I appreciate that, they're defining the 1A healthcare worker as someone who goes from home to home to home and comes into contact generally with multiple different individuals, and therefore can put multiple individuals at risk. And so their definition of that is not the wife who's caring for their husband. So unfortunately, those caregivers sit in their appropriate category. And so if you're the 40-year-old generally healthy person who's taking care of their 85-year-old father, though he can get the vaccination, unfortunately, I can't just say it's okay, you can. That's a very frustrating answer for people, particularly if you're living with someone who's had a transplant or someone who's going through stage 4 cancer and is, very immunocompromised. But the exceptions, the state has not given us those latitude for those exceptions at this point.
Thank you, Roberta. Okay, so I'm going to end us on one last set of questions here. We get asked this one all the time as well. Is, okay, we hear, and the Pfizer comes in 5-dose vials, which almost uniformly we squeeze 6 out of. In fact, as y'all have probably read, the labeling is going to change on those to be 6 per vial going forward, and Moderna comes 10 per vial. So either way, if you're at the end of the day, if you've cracked open a vial at a site, you may have 1 or 2 or 3 or 4, or even could theoretically have even 8 or 9 if it's Moderna. Now we're mostly Pfizer now, so it's really we're all Pfizer now, other than second dose. So talk about how we manage that process, that we don't ever waste a dose, and about this issue of, is there a wait list, and kind of come in and get it, and who do we put on that list?
Yeah, so if you, and this process has changed over time, so there's a good likelihood you have met somebody that stood around at the end of the day at whether it was HEB or Houston Methodist and kind of waited right outside the door to get that last dose of vaccine. And at the beginning, when we were getting our sea legs, that did happen. At this point in time, we've gotten more sophisticated. So we've gotten more sophisticated on 2 fronts. One is predicting exactly how many doses and how many appointments we will need, as well as even a no-show list to be able to say we're getting exactly there. The second one is we developed a wait list off of those individuals who actually fit into these categories. And so we looked at kind of a geographic who lives right near the site, who fits into the 75 and above and 65 and above, who are already in our database of someone who's in our Houston Methodist list or is in the public list that can get there very quickly. And we're able to call a certain amount of them and say, if we called you tonight, would you be able to come? So our wait list is from now our own population of data that we have, or our lists of people that we have collected. And so I would say to you, at our sites, please don't come and stand outside the door. It is very unlikely that you are going to be a person who will win the lottery. It's become far less likely than it was in December, when at the end of the day we went, oh my goodness, and started getting on our phones and calling those people that we knew were in 1B. That's not happening so much anymore.
Great. Well, thank you for that, Roberta. Well, I want to thank everybody for attending today. Hope you found this very useful. We, again, with all these vaccine questions, I think we spent over half of our time today answering questions and got to the vast majority of them and embedded, I think, most of the rest within our remarks. So, Dr. Sostman, thank you, Dr. Schwartz, both of you, for being here today, doing a great job as always. Next month, our next session, we're actually going to have COVID updates again. It is on Thursday, March 4th. But we're also going to talk about our Center for Outcomes Research, which actually was already stood up prior to the COVID, but it's really hit the big time during COVID as, of course, there's such big data needs both to understand what's going on during COVID, after COVID, COVID recovery, and all of those activities. So you'll be hearing from a couple of our experts giving more data around that. With all of that, I want to thank everybody for being here again. Thank you for your support of Houston Methodist. Thank you for your support of our employees. Last time I talked about cookies, and a couple people went out and baked and sent cookies in or bought cookies, and I want to thank each of you. I'll tell you, this can't end soon enough. We got people running on fumes right now after a year of doing this as our teams, and of course, going through the third surge. I mean, they're veterans on one hand, but on the other hand, they're tired. So this next surge can't come down quickly enough so that we can really get to some sense of better normalcy. So please help us with that. Please help us with doing all the right things in the community to keep that curve coming down. Get vaccinated, obviously, when it's your turn, when you have a chance. God bless each of you, and thanks so much.